Hi, my name's Travis. I'm an ST1 in intensive care, and today I'm going to take you through end-of-life prescribing. I think when dealing with end-of-life patients, it can be really quite overwhelming. It's a very emotional topic, and you'll typically be dealing with lots of people's family, friends, in a very, very difficult time for everyone. And I think it's really easy to feel overwhelmed, and so I wanted to just put in the beginning that it's never a problem to ask for help, especially when dealing with these teams. And typically I find that palliative care doctors are extremely supportive and always willing to answer questions, whether it's for your learning or just because you're not sure what to do. So always feel like, especially if your team aren't around you, you can reach out and ask for help. That being said, I think when you're dealing with dying patients, you can break down their management into three distinct categories: their medication, their nutrition, and then other things to be aware of. And the biggest part that we're going to focus on today is the medication, just to make sure that all the symptoms that they experience as they come to the end of their life are dealt with in a really, really controlled way. And so the way we're going to do that is we're going to have baseline medications, as well as having anticipatory medications, just in case things change. Because we know during the process at the end of their lives, things can change quite quickly. However, something to be aware of is definitely the nutrition of patients. And actually, patients should be supported to eat and drink as much as they are able to. And any decisions on hydration and nutrition should be individual to the patient. We won't be able to say that one person should or shouldn't have fluids, one person should or shouldn't have anything. It's deciding based on the symptoms that the patient has, the best things for them, and trying to prioritise nutrition in that. Finally, the other considerations that I would have for all patients is monitoring of their clinical condition. And lots of places may have a protocol for this in terms of how their end-of-life patients are reviewed. And it's worth checking how this works in your hospital. This should lay out the goals and responses to any treatment, as well as what treatment is actually indicated. What is the limit of what we're going to do for these patients, and ensuring that we know where that is and what the plan is in case certain scenarios present themselves. It's always worth remembering any carers or also family concerns and anything that they may need you to help with, as well as what is a sign of recovery. It is not a problem if somebody shows signs of recovery to change an end-of-life decision. However, this should be a joint decision between palliative care as well as the medical team or surgical team looking after the patient. So, looking at symptoms, I've gone through the typical ones that the Royal College of Physicians advise on. That being said, I've never worked in a hospital that doesn't have extremely clear end-of-life prescriptions. And so it's always worth checking in your hospital what they like to give and in what order. That being said, I think a lot of the things listed here are quite commonly in all end-of-life prescription policies. And certainly in my hospital, this is almost replicated on the back of our prescription sheets. So the first symptom and the most common one that you'll be asked to go and review is pain. People at the end of their lives will always report pain. And we want to ensure that they are as comfortable as possible without actually putting them at risk. This is commonly done with a morphine-based substance, and so this is either going to be morphine or fentanyl. The indication for using fentanyl is if anybody's got a poor renal function, which isn't uncommon at the end of life. And what you'll see is actually most patients will end up on small doses, but very, very regularly, and these can be titrated up. Of note, you'll see that all 6 medications that we're going to talk about here are given subcutaneously. It can become difficult towards the end of life to swallow, and typically we don't want to be recannulating people as they move towards the end of their lives. And so a subcut line can be placed, and then all medications can be given through that. So typically we'd start with 2.5 milligrams of morphine, and they can have that up to hourly, and this can be increased. However, what's really important to notice is that the reason to change this would be the respiratory rate. And so we need to be monitoring these patients' respiratory rates and ensuring we're not giving too much morphine to patients. Similarly, the starting dose for fentanyl is 25 micrograms, so it's really important to make it clear on the drug chart that this is micrograms. It's very rare to give alfentanil. What you would then do is notice how often the patient is using their PRN medications and potentially increase them each day based on patient needs. And if this is something you're not comfortable doing at the beginning, that's fine. This is something you can discuss with the team or palliative care. Typically, if you were asked to start just in case medications or anticipatory medications, you would start them all at the beginning and then titrate it up over the following days. The second thing that patients can present with is agitation. And so this is just as they kind of become a little bit more confused and things are changing, you may need something to settle this. And so it's really important to notice whether they're agitated and delirious or aren't delirious. If they aren't delirious but just agitated, then the first line would be midazolam. And we start this at 2.5 subcut. And again, all of these are PRN, so they don't have to be given, but they can have it up to hourly. If they are delirious, you would still give them midazolam, but you may add in a small dose of haloperidol or levomipramazine. This is the first time I would say that it's worth checking exactly what your policy says, because, for example, I know where I work, actually the levomipramazine is our first line with delirium, not haloperidol. Thirdly, we're going to look at nausea. Okay, and so we need to identify the cause of our nausea, and if you haven't already seen the antiemetics video, we've got a detailed description there, but you'll notice here some of the medication options are different, and this is because we know that we're going to be giving lots of antiemetic and also subcutaneously over a long period of time. So we need to know whether or not this is a chemical cause or this is something that is happening because of the processes happening in the body. If it's something that we think is caused by the sickness, then we'd start with cyclizine and secondly go for levomipramazine. Whereas if we think there's a chemical cause, we may use haloperidol in an antiemetic property. And you'll notice that the dose here is 1.5 to 3 daily, whereas for delirium, we had 0.5 to 1 up to hourly. So the indication here is a very different dose. Fourthly, we need to think about respiratory tract secretions. We know that people produce a lot of secretions as they move towards the end of their lives. And so typically we would start this with hyoscine butyl bromide, which is called Buscopan as a trade name. Typically we'd give 20 milligrams subcut up to hourly. And although alternatives are listed here, I've never required any more than just hyoscine butyl bromide. Finally, breathlessness can be treated with morphine or midazolam if you're not using them for one of the other indications. If, for example, you're using morphine for pain relief, but there is no agitation, then that's a good indication to use midazolam in this instance. Similarly, you may find that you're using midazolam but no morphine, and so this is why the alternatives are there. If you're asked to prescribe just-in-case medications, the best thing to do is to prescribe the first line from every category PRN. And these might not get used, but it means that they're there, that if a patient needs them, they don't have to wait for a review in the middle of the night to start these medications when someone's moving towards the end of their lives. Because we know a lot of these effects are going to happen, it's just a case of when. Just a note on syringe drivers, unless you're confident and trained, I wouldn't necessarily initiate syringe drivers. This is something that should happen as a conversation with palliative care. Similarly, if somebody's on a syringe driver, and you're asked to increase the dose, this is something you can look into doing. And it's worth asking palliative care about how they do it before you do. Typically, you would take the amount of PRN medication that they're using on top of their syringe driver and then increase a fraction of that, typically 50 to 75%. People are allowed a little bit of variation. However, if they're constantly requiring more pain relief or agitation medication than is in their syringe driver, that's when we'd look to increase it. Finally, just to summarise, if you're unsure what to do, it is always okay to help. And I think this is something that I would really stress with palliative care. These are really complicated patients, and actually keeping them comfortable can mean that you feel like you're forced to do things you're not comfortable with. And this is when you should ask for help. Most hospitals will have really good end-of-life guidelines, so it's worth checking. I've never worked yet in a hospital that doesn't. And palliative care are a really, really open and willing team that are always keen to teach, as well as give advice if you're not sure what to do. So please ask. Finally, I just wanted to say that the doses of medication that you'll give in the end of life are different to what we typically prescribe. So please don't transfer that over to your normal practice. You wouldn't typically be giving hourly fentanyl or morphine for other patients like you would at the end of life. So that's worth just bearing in mind. I hope this video has been useful. Thank you for listening, and I hope you'll take a look at other 10-minute medicine videos.